with this up here is you get to be a teacher to your patients. You get to teach them about what's going on, what matters, what doesn't, the plan, how to do that, why it matters. Anybody have a favorite there? Hey, Ron, big fellow. How about the black and white picture up the left? Anybody know who that is? The profile, the girl in the profile may be more famous than the full picture. Helen Keller. Exactly. Who is Helen Keller's teacher? Also known as the miracle worker. That's what she's known as. Anne Sullivan. There you go. An inspiration. You can teach a deaf, dumb, blind, dumb, mute, blind person to be what Helen Keller turned out to be. That's a pretty good teacher. All right. Well, in panic disorder, some of the things in panic disorder, to finish up the anxiety lecture, that are part of a panic attack are derealization. So we think of Thanos with the reality stone in the glove, right? It's things around you, the world around an individual experiences unreal, dreamlike, distant, or distorted. That's what derealization means. So a panic attack we need 4 symptoms of. This is one of them that could be. And worried for a whole month. So if you think of Thanos in the panic attack, he's got 4 fingers, and you're worried for a whole month that he's going to snap those fingers and complete that thing. So 4 symptoms plus 1 month, and Thanos might connect them. Whoa, that's panic disorder. 4 symptoms for a whole month. Thanos. Depersonalization, that's like an out-of-body experience. So Spider-Man, Doctor Strange, yeah, sorry, spoiler alert, is there anything there? You're feeling detached from an outside observer or one's mental process, having an out-of-body experience, that's what depersonalization is. Here's a big box for panic disorder. So you need 4 of those symptoms, plus how long? 1 month, we're worried about happening again, that Thanos is going to snap his fingers. That's panic disorder. So panic attack are the symptoms. Panic disorder is 1 month or more of worrying about that happening again. There's a big box continued. Read that, make sure it makes sense to you. And then what do we do for it? C, B, T. Loud and proud. Yes. It responds just as well, this condition just as well as meds. So if we had a choice between meds or no meds and they have equal efficacy, we're going to choose no meds. Right? So relaxation training can be also effective as meds. So what is relaxation training? Going way back. Bad Boys 2, Will Smith, Martin Lawrence, and their captain, Howard, would get nervous because they push the envelope and they would come back to the captain and say, "This guy, relax." So just hold your earlobes and say, "Woosah." And so the captain, Howard, would be the rest of the movie. Woosah, woosah, woosah. Relaxation training. There you go. Silly dad jokes. We get to remember things, hopefully. If we get to meds, what do we use for panic disorder? And there they are. First line antidepressant. If we need a bridge, benzo, but be careful. We don't like using benzos long term, so just a bridge while that antidepressant starts working. And then miscellaneous, if it's predictable, then propranolol, or if we get 2 birds with 1 stone, if they have other comorbid things that propranolol, but if beta blocker would help with, then we would consider propranolol. That's why it's on the bottom of this slide. It's on the bottom. Next, agoraphobia. Something that's kind of unique, or maybe people don't associate with agoraphobia. Agoraphobia being in crowds or being in situations where you don't feel like you can get away, or you can't get help if you need it. That's really what typifies agoraphobia. One of those is being in open spaces. Being in wide open spaces far away from things that you can't get help with. So that's, to have this disorder, you need to have those conditions in at least 2 arenas. So you gotta have at least 2 spaces that is prevalent in. And that's an indicator or a distinguisher with this one. So they just have one, it may be a specific phobia, but if it's in 2 of these, then you're in the realm of agoraphobia being a possibility. Always evoke the anxiety out of proportion to persistent for 6 months. Yeah. And you'll see in anxiety, the time component is 6 months and less than 1. One disorder in here that's less than 6 months. Which one is that? We're worried for a whole month. Which one is that? Panic disorder. That's the only one that's not 6 months in anxiety. How about that? Differentiator. All right, pertinent info. What else could it be? There's a list there. It's considered a disability, and it greatly impacts, as you can imagine, if you're nervous about, worried about being around a lot of people or in a position or a situation where you can't get help. More than a third of the individuals live alone, and so you think, all right, which happened first? Did you live alone and then develop this, or did you develop this and then live alone? Chicken or the egg? And so you ask your patients and get to know them and seek to understand that. There's the pink box for agoraphobia. Read it. Make sure it's not better explained by another diagnosis, right? And then what do? We get around people who have the same condition to be able to understand, hey, I've done this and I've been through this, I'm a little further along than you, you're a little further along than me, and you learn from each other and say, you know what, it's not a big deal. After I only flipped the switch 13 times, not 12, where I was around, I rode the subway to work today, and I was okay, believe it or not. If we need to get the meds, these are the meds that we use. Muhammad Ali, right? SSRIs, SNRIs. And I keep putting gabapentin in there. It's off-label use. I'm not going to ask you a test question that the correct answer on the test would be an off-label use of a med. But I just want you to have that awareness because you'll see it quite a bit in clinic. And so that you understand what's going on. And gabapentin can make you better, which may be a good thing. Did you catch that? The treatment for agoraphobia is to get in a group. Or seriously? Yes, seriously. It's actually the treatment, is to get together. But it's true. And it works, if you can get them. Next, generalized anxiety disorder. This one has a low threshold for diagnosis. One of those that we talked about at the very first of the bar being lowered for a lot of diagnoses because we want to get treatment in there early and intervene. This is one of those where the threshold is pretty low. In non-discriminatory worriers, they're all comers. They'll worry about whatever you bring to the table. Yeah. Basics of that: excessive worry, multiple things, a lot of different things. I heard a patient describe this once as a wet blanket of worry and frustration that sits over all of their life and mood. That'd be pretty bad to live like that, wouldn't it? When you get a chance to intervene, you get a chance to enter into that patient's life and world and help them build a plan, help them get better, and take that wet blanket off. So good. Remember what fear is versus anxiety. What is fear? Emotional response, yep. Immediate response, there you go. Immediate emotional response, so we're responding to an explosion. Whereas in anxiety, what would we equate that to more so? Imaginary, chronic, yep. Future threat, possible, say again? Anticipatory, what if it might happen? Yep, kind of slow burn, always, of something that might happen in the future. Exactly, no, got it. TAC, right now. There it is, distilled from the pink box. Excessive worry about multiple things. That's a key thing. It's multiple things, a lot of different things. Time component, 6 months again. In our anxiety, all but one of those diagnoses is 6 months. And then we need at least 3 of those symptoms. What questionnaire would we give a patient to see about this one? GAD-7, exactly, that helps us. That's not a diagnostic tool, but it's a data point. So I say diagnostic tool. It's not in the diagnoses to say criteria. You gotta have scored this on a GAD-7, but it definitely helps you gather that data and information. So I use it a lot. So I would encourage you to use it too. So 3 of those symptoms, you can look at those symptoms. It looks pretty consistent with what we're talking about. Notice something in there that we haven't seen before in that list. Muscle tension. Yep, muscle tension we haven't seen before. And that's pretty unique to this one as well as far as diagnostic criteria. And so if that's in there, you might think, oh, I better put that on my differential. Generalized anxiety disorder, muscle tension. Neck, back. A lot of times people say they wear their stress, or that's where it manifests itself in their neck or back. So their neck will get tired or wake up with a stiff neck after they've been worrying about a lot of stuff. So think about that. If that patient comes in with that. Increased suicidal, so we gotta screen for that always, right? There's our pink box. What do? CBT. Yep, thank you. Good job. For the 2 of you that said it out loud, good job. Relaxation training, woosah. Combos better than some spray. This is looking familiar, right? Anxiety treatment, looking familiar. Wash, rinse, repeat for the most part. There's our relaxation training. And if we get to meds, there we go, looks familiar, right? We start with antidepressant, Muhammad Ali and friends. If we need a bridge, be careful, benzos. And then down on the bottom, those miscellaneous is a little bit different, or we introduce buspirone. It's an adjunct. It's not a first line, but it's an adjunct anxiolytic. So that's one that comes from our med lecture that you got open in the background. You can look at buspirone. Let me look that, there it is. Anxiolytic. Good job. There's another example. Again, same example of our GAD-7. Don't show them the score when you hand them this piece of paper to fill out. And then I'll be not only initial, but follow-up to see how they're progressing. Getting worse, we need to change something. We need to add, we need to get a little more involved. Or getting better, let's keep it going. Do y'all have this slide in your lecture? No? Okay. I don't think my internet's working, but this is an old school video of Bob Newhart. You can just Google Bob Newhart, stop it. And that's it's what you don't want to do to your patients. That's related. That's good. You're welcome. All right, let's look at anxiety practice a little bit. And first we'll kind of lay the groundwork. Kind of the same thing we did with depression. Get your clinical gestalt. I'm not going to ask you to differentiate between mild and moderate, but this will kind of help you understand when to employ these things in clinic. So mild, if it barely meets those criteria, like if we're generalized anxiety disorder, how many symptoms do we need for generalized anxiety disorder? 3. And how many months do we need? 6 months, yep. Every anxiety disorder is 6 months except for which one? Panic disorder, how long is that one? 1 month. We're worried about Thanos snapping them fingers. Hope we're on the list to stay. Well, I just got turned off. I had a depersonalization experience there. Out of body. All right, start low and go slow if we need. We start with our first line of treatment, which is what? Say it loud. Good. I hear you. Preach that. CBT. So that is a form of behavioral therapy, right? Cognitive behavioral therapy, CBT. If we need meds, we might not need meds in somebody that's mild. So we're trying to avoid benzos in somebody that's mild. We want to keep them away from the candy. Because that, I think they'll be okay without it. And then follow up when we need to check on how they're doing. Moderate is that next a little bit more severe. They meet the criteria and then some. That one you might start a medicine today and you might consider an abortive medicine or something like a bullet, Barney Fife in his pocket just in case. Remember Andy, the sheriff, Andy Griffith doesn't let Barney carry a weapon with bullets in it. He said you gotta take the bullets out. You put one in your pocket, just know you got it. And so he carries an empty weapon. So that's what you give one bullet in the pocket for someone like this, to say, you got it in your pocket, that makes you feel good. So you probably won't need it because you got it in your pocket, because you know you got it, just in case. If you don't have it just in case, you worry about not having it. And so that makes more work. See what's going on there. Okay, so main, benzo, careful. Schedule a little closer follow-up. When we prescribe an SSRI, how many appointments do we have follow-up right there? 2, exactly. 2 follow-up appointments. When's the first one? About a week. Yep, what are we looking for there? Side effects, yeah. What's a common side effect for an SSRI? Agitation. What's 30 to 50% most people get SSRI? Sexual dysfunction, exactly. Yep. What if it's not that bad? What if you just notice it? What do you tell them?
Wait it out.
You can tough it out, it'll probably go away in another week or so. Good. Yep. What's a dangerous but rare side effect for SSRI? EPS? Yep. What's the other one? What's the black box warning? Suicidal ideations. Yeah. What's another one? Serotonin syndrome. Yep. Those are rare but dangerous. So remember, rare but dangerous and common. Good job. Good job. What's the next follow-up appointment? When do we see him back for next? You said 4 to 6 weeks? Yeah, good job. What are we looking for there? It's working. Yeah, exactly. We wait that long. And then some conditions take a little longer to kick in, like an OCD. How long does that take? Like 12 weeks or so, like 3 months. Yeah, we're a little more patient with that. Good job. Now, if it's severe, we are going to start them on something today, and we probably are going to give them an abortive medicine, and they're going to give maybe a few more than just a bullet in the pocket, because we're worried about them doing things that hurt themselves, right? So that's one that we lean in a little further. We have strict ER precautions, and you go to the ER, if you feel like hurting yourself, you tell them I sent you, you tell them what meds you're on, and we'll blame it on the med, okay? So they're not the bad guy. They're not the one admitting weakness, which is a big deal in the military, of raising your hand to say, I'm weak. That's what they think they're doing. You take the blame as a provider and free them up to seek that care. Good. All right, let's practice. Here's a question. Actually, 3 questions based on that statement. What's the first thing you want to know about this patient? A little more information. If you're in clinic with this patient, what do you want to know? What's rare but dangerous? Suicide. She has any suicidal ideations. I want to check with her first. How are you feeling? Are you safe? Do you feel like hurting yourself? All right. So you start there. Good. We have a time component here. 7 months. What are we talking about? What lecture are we in today? Anxiety. What time component do we need for anxiety diagnosis? 6 months. So we've done that. Good. What about what condition are we thinking about here? Lots of things. How many? We'll just say generalized anxiety disorder. Okay, I'll give you that one. How many symptoms do we need? 3. Do we have 3? Yeah, we do. Fatigue, restlessness, irritability, decreased concentration. Is this clinically significant? It's in question. She's seeing you, talking about you. Yeah, yeah. Adult or child? Adult, male or female? Childbearing age?
Yes.
Yep. Where are we? Does it specify emergent situation? Okay, so we can't assume. Can't bring in. Well, I think this might have been done, and this is. I'm assuming that this is a. Take what's given to it. Good job. Is it attributable to a substance, or better explained by another condition? Are we given an illicit drug here, or another med that they're on, or a medical condition they have? Nope. Good. So, Gab, what would you say severity is on this one? Mild, moderate, I respect that. Yep, mild to moderate, somewhere in that room. I call it mild. There you go. There's what we're going to do for them. Danger, no danger. What's going to kill this patient? What's top of the list of probably what's going to kill this patient? Themselves. Yep. So that's top of our list that we want to make sure that doesn't happen. What's going to kill your patient? Take that off the table. So address that. Good. Be a source of hope. Make a plan. Next one. What else would you like to know about this patient? SIHI? Sorry if I interrupted you reading. Adult or child? Male or female? Where are we? Stable or unstable? Stable. SI or HI? We don't know, do we? Okay. We're not given SI, so we can't assume that, but I'd like to know that if I'm talking to this patient. What's the time component here? 2 years, so we're over 6 months, right? So we tick that box. How about number of symptoms for GAD? How many do we need? 3? Yep, do we have it?
Yes.
Yeah, we got that. And some. Yahtzee, we got all 6. Is this clinically significant? Affecting his life? Yeah. Is it attributed to another substance or medicine condition they have? He has? Nope. Good. So you'd say GAD, you'd say generalized anxiety disorder? Yep. What severity would you call this? Okay. I'd call it moderate. Okay. We don't have any SIHI, so we're in that moderate range, but I respect overcalling. I'd rather you be more cautious than less cautious. So I respect that. I call it moderate. When you get in clinic, you'll kind of get that gestalt for it as well. Gestalt, you don't know what that term means. You know what that is? Gestalt. It's a German word that means it's made of many parts, but you see it as a whole. So if you see a patient with a lot going on, but your gestalt is, I think that's GAD. I think that's generalized anxiety. That's it. That's a wisdom to be able to apply knowledge in the right time. Gestalt. There you go. A little language. That was free.
Sir,
Yep.
can you explain why that's not severe disease? We know there's a scholarship,
We'll give a severe example, and then hopefully they compare someone else. So yeah, I'm not saying you're wrong, but we'll compare it and just see. Next practice question. Adult or child? Oh, child. Does that change our criteria? Yes, it does. What do we need? There's one symptom. Okay. Good job. How about time component? 6 months. Do we have that? Good. So adult, child. We got child. Male or female? Male. Okay. Where are we? Don't know. Stable or unstable? Okay. We aren't given unstable, so we got to assume stable. Good. We got the time component. We got a kid. What's the diagnosis here? It's not GAD, right? What do we need for GAD? We need a symptom. We got no other symptoms, right? So as far as the diagnostic criteria go, this is not generalized anxiety disorder. So that's one where we want to help this patient. We treat the person, but as far as diagnosis and what we put in their record, we can't put that in their record. The treatment may look the same, but they meet the criteria. No, can't put that in the record. Don't overcall stuff. Don't reach for a diagnosis, but still treat the patient, treat the person. Good. What do you think the severity of what's going on here is? Not that bad? Mild? Okay, I agree with you. What would you do for this patient? CBT, exactly. Everybody needs a checkup. Yep.
Is excessive worrying not a symptom?
That's part of the first of it. It says excessive worry about many things plus symptoms. Yep. Good question. Good question. If you're asking about what to call this, your ICD-10 code, this comes from the definition slide, right? The catch-all after we've railed out everything else. We treat the person, not the diagnosis. Good. Change the course of life. Intervene early. 15-year-old, you don't want to just say, buck up, camper, it's a good day, send them out. You want to intervene, help them out, get that CBT started. Adult or child? Adult. Male or female? Female. Where are we? Non-emergent. Yep. And we also have at the bottom there, denies SIHI, so that's a good thing, right? You got a time component? More than 6 months? Yup. 5 days a week. Do we have symptoms? You got 3 of those. Hypersomnolence, muscle tension. Ooh, there's one. Decreased ability to concentrate, being short and irritable with children. Is this clinically significant? Is this attributable to something else? Drug, condition, med? Not that we know. What would you diagnose this with? Generalized anxiety disorder. What severity would you call this? Okay. I said mild, but I respect that. I'm not saying you're wrong, but just knowing where that is, we're kind of on the line there. I appreciate that. How about if we change the next part of it? Same patient, just change the last part. What would you classify this severity as? A little more? Moderate? I think this bumped it up to moderate in my mind. What do you like about that, what's in the red? Something in the red you like? Self-awareness. How do you know that? Say again? She's got it nailed down. She knows why. There's a lot of different things there, but yeah. She's got it nailed down, but what has she done? Took an online course, didn't she? She wants to get better. She's putting in the effort. And so you want to applaud that. You want to highlight that and say, I'm confident you're going to get better because you're putting in the work. You want to get, this is a great sign. Way to go. You're awesome. I want to help you. You point that out to her instead of saying, you just wasted your time. Because the online course might have been basket weaving, and that might have been more frustrating to her. But the fact that she signed up for it for the intention of helping with this, you want to applaud that. Say, all right, let's clean that up. Let's get it pointed in the right. Let's put a finer point on this. Let's get it. I'm excited about potential for you. So you speak into that. Speak life into this person. There you go. There's a moderate. Applaud her efforts. Get that help, and that she's doing that on her own. Would we give an abortive medicine to this patient? What might give us pause for abortive medicine for this patient? Think about the patient and her situation. I think you said it. You got kids at home. Yeah. You drug her up with kids, and that being a responsibility, you want to think twice. So think about the situation. Take that social history. What's your home situation? And you don't want to give somebody benzos, then that she's responsible for kids, right? You give her something that's maybe a propranolol, right? For those PRN, those that bullet in the pocket. Check her blood pressure before. Good. All right. How about this one? We're spending a lot of time on this because you'll see this a lot. All right, adult or child? Adult, male or female? Where are we? Emergent? Stable or unstable? Stable. Good. Why is she here? Is there a time component? Several years, so we're over 6 months. Yep. Worried about stuff. What's she worried about? One thing? A couple things? Few things. Yep. We have symptoms. We have 3 symptoms. Irritability, concentration deficits, fatigue. Yep. We got enough. Is this clinically significant? She's talking to you. Yep. She got something else attributed this to? See anything else in there? Nope. What we call this GAD? Yep, we would. What kind of severity would you put on this? Maybe moderate. Okay. Appreciate that. Getting into therapy sooner or later. Everybody gets it. CBT. Yep. Would you start her on a med today? Conversation with the patient, but it's more likely that we might start one today. Yep. Would you give her a aborted med? Give her a benzo? I don't like giving anybody benzos, but I would less like her. She's got kids as well. We gotta watch out for that. Maybe propranolol. Careful. All right, next one. All right, adult or child? Adult, male or female? Male. Stable or unstable? Why are they here? Why is he here? Follow up for what? Yeah, right? We're giving right there. We're giving the diagnosis. Good. Is there any reason to make you think that that's a misdiagnosis? Okay. Nope. Duloxetine, CBT, decrease in libido. What do you think about that? You see him at 1 week, what are you going to tell him? Yeah, don't just tell him, hey, self it out, but have that conversation and say, how bad is it? Is this mild? Got it. It'll likely go away and get better from here. And they say, okay. Or, hey, no, it's too much. Then what would you do if he says it's too much? Switch, yeah. What if you switch to a different class of med? What do you need to do? Wash out, let that wash out. What if it's fluoxetine? Wash itself out. What do you need to do though still? Everything washes itself out, and so I appreciate it, yes, correct. The fluoxetine, you don't need to titrate down. You don't need to decrease the dose for them. You can just stop taking it right away because fluoxetine has that long half-life and it'll taper itself out of their system. But we need to wait for that to happen. When we taper down the dose of another med, we still need to wait till it gets out of their system before we start another class of it. Does that make sense? Yeah. Good. Maybe switching. There's duloxetine. There you go. GAD treatment. There you go. Now I told you we would look at a severe case, but I don't have one here. Sorry, I thought I did. I wouldn't fault you for calling that other one severe and going there. That's the conversation. When you put eyes on that person and to say, you know what, I'm not worried about you because you got a handle on things and you're coming to me because it's starting to get out of control, or somebody who says, ooh, their hair's on fire and stay here, don't move, and I'm worried about you. So you'll have that as your emotional IQ when you look at that patient. So I can respect saying calling that other patient severe. That's fine. I'm not gonna ask you to cut that on a test. Good job. There you go. All right, let me switch slides real quick. All right, let's practice. 4-8. All right, what's the question? Diagnosis and most likely. Right? When it says most likely, it doesn't mean we gotta have all of them, and it says which smell the most like. Adult or child? Adult, male or female? Male, stable or unstable? Stable or PCM, right? Why is he here? He wants immunizations. All right, good on him. He wants to be prepared. Good job. Why is he really here? He's afraid of mosquitoes, yeah. He's afraid of mosquitoes. What's the most deadly animal on the planet? Mosquito, besides me. Dead. Mosquito. Exactly. So it's not terrible, but think about the context. Where is he going? Alaska. Is Alaska a malaria endemic area? What's the next? No, it's not. So it's not a malaria endemic area. And where did why is he scared? Because his dad got malaria. Got it in Africa, different place, yeah. So what are we talking about? What are the pertinent positives and negatives here? Do we have a time component here? Teenagers, so yeah, that's what, at least 7 years, no math, right? Yep. Is he actively avoiding mosquitoes? Is it out of proportion to the real danger? Alaska endemic area? No. Has it been more than 6 months? Is it clinically significant? His word. Any of these that are not diagnoses? What's PTSD? What's post-traumatic stress disorder? We don't know. We're going to find out in a minute. We don't know. All right, so that one's off there. We've got 4 left. What's agoraphobia? Greater than 2 areas of what? What are we doing in those 2 areas? What's one of those areas? Give me an example of the most common where you think of agoraphobia. Crowds, yep, being crowded. And what's another one we don't think of agoraphobia? Wide open space. What's the commonality there they're afraid of? Not being able to escape or get help. Yep, that's a commonality. That's kind of the underlying fear of those places. Good. Social anxiety disorder. What's the key characteristic of social anxiety disorder? What about glossophobia? Standing up here in front of people and talking. What's the fear that comes with that? What's being judged, other scrutiny from other people, social anxiety disorder, being scrutinized, being exposed to scrutiny by others. Any of those? This guy? Alaska's got wide open spaces, that's not what he's talking about, right? Fear about being scrutinized by others, he doesn't care what you think, he just wants a shot. How about specific phobia? What's the specific phobia? Okay. Malaria or mosquitoes, you put that in there. One thing, yep. Focus them on it. Panic disorder. What do you need to have panic disorder? At least one. An attack. What's an attack look like? Looks like stimulant intoxication, right? Woo! Everything's going up. Sweat, heart rate, anxiety. We have that? No, we might. We're looking at it, but we don't have any questions. PTSD, we're not going to talk. We'll talk about that in a minute. Good job. Way to go. He had it all. Specific phobia. There's a big box. Next question. And this is one of those questions where if you don't read the question first, you're reading through it and you go, oh, I know what this is. And then you get to very treatment for, oh, they assume I know what this is. So what are we looking for? What's the question?
Best treatment.
Best treatment. Not just a treatment, best treatment. Okay. So there might be more than one that's correct, and it's probably the way it is if it says best. So more than one of these would work. Which one's the best one? All right, male or female? Female. Oh, mixed it up one. Adult or child? Adult. Stable or unstable? Stable. Yeah? What would make it unstable? Get hurt. SI. Some sort of vital sign out of abnormal, right? Good. So we're saying stable? Okay. Good. What does this smell like? What does this look like? Gag? All right, we got that chart in the upper right. When you're taking the answer test, you're supposed to be given normal range on lab results or things. So there you go. There's what we're looking at. So you have a GAD-7 score of 18. What does that tell you? Severe. There you go. There's another indicator of if we go moderate to severe is your GAD-7 score. Okay. So we're up there. What do we treat GAD with? CBT, SSRI. And then if we need a bridge, maybe a benzo. If we don't like a benzo, we can replace that with propranolol, maybe, something like that. Okay. All right, let's see if we got that in here. Here's the pertinent positive negatives in there. We got enough to diagnose it. Good job. What kind of med is sertraline A alpha? SSRI. Follow up in 3 to 4 weeks. Is that a plausible plan? Okay. What else would you like to do before that? CBT. Good. And when would you like a follow-up before 3 to 4 weeks? 1 week. Okay. But that still works, right? See if we got it better. Bravo. What kind of med is duloxetine? SNR. It's emerald. Bam! We kicked it up a notch. Added a neurotransmitter in there. And oh, we love CBT. Don't let it distract you though, but we love CBT. And follow up in a month. Is that a bad plan? So yeah, it's a bad plan? This is a good plan. This is it. I should have asked a positive answer to that. Good. You like C? Okay, that's all right. You like that one? How about C, desensitization? And purine nightly lorazepam. What kind of med is lorazepam? Benzo. What does benzo, lorazepam, purine nightly? What would that be given for most likely? At night. Insomnia, sleep, to be a bridge, purine nightly for that. What do you think about that plan? First of all, desensitization. When we talk about generalized anxiety disorder, did we talk about desensitization? Why not? We're going to desensitize you to the world. So, that's tough to do. So, desensitize somebody from everything, that's not a part of the treatment for GAD. If you can pinpoint things, then yes. But in GAD, it's excessive worry about many things. So, it's not a part of the treatment plan necessarily. And then purine nightly lorazepam, is that what we're going to start with meds? No, maybe throw them in my mouth a little bit with this one. Okay. D, Delta review, sleep hygiene. Is that a good idea?
Yes.
Yeah, that's a good idea. What's sleep hygiene a form of?
Make sure you get off your phone.
Sleep hygiene is a form of what? I learned this from another class. Anybody else sign language? Like, what's up? Appreciate that. Okay, man, back on track, we got off there. Lorazepam, yeah, whoa, careful, I don't like that one. E, massage therapy, abstract care, cover babysitting. All the moms in the group said, that's the one, that's the one. Okay. What's the best treatment plan? Which one do you like the best? Bravo, good job, good job. CBT and an antidepressant, good job. There it is from the diagnosis. There's the pink box, there's the treatment. Y'all are killing, crushing. There's from the med slides, or actually treatment. There's from the med slides. There's Emerald. There's where it follows there. Benzo, okay. Just remember, danger of candy. If you take benzos a lot for sleep, and then you come off of them, you can have that rebound insomnia, right? Because your body starts getting reliant on that for sleep, and then if you don't have it, your body wakes up more. So you can have a tough time getting them off of it once you're on it for sleep. So don't recommend it for sleep. Short-term bridge, yes. All right, next question. All right, first of all, we see propranolol, and we're in psych class, so that kind of helps us. But propranolol, what do we talk about when we say propranolol? Say again. Predictable. Yep, what's predictable? What's the most predictable in this crowd? Social anxiety disorder. Okay. Agoraphobia? Could be, right? You know you get on the subway every day. Could be. Okay. But it says most appropriate, best, most likely. That's kind of what you're looking for there. Good. Elder emotional abuse, if you give propranolol to somebody who's already slowed down, bottom them out, you can't predict abuse necessarily, right? Interpersonal violence, hopefully you can't predict that either. That's what your escape plan is for. Social anxiety disorder. Good. Probably works for a couple of them, but the bestest is that one, social anxiety. Good. All right, let's take our 10-minute break a little early. You got a couple minutes. Hey. Here's where to find it in our reference material. Here's what we're going to talk about today from your syllabus. This is a catch-all term. After we drew out all the other ones that kind of smell, doesn't meet the diagnostic criteria for the others, this is a diagnosis of exclusion more so. Don't jump straight to this one, unspecified. Remember these dissociation symptoms, dissociative symptoms. Remember what depersonalization? Who's our poster child for that? Spider-Man, Doctor Strange. Out-of-body experience, yep. And then derealization. Who's our poster child? Thanos, yep. With which disorder? We talk about that. 84 symptoms. Panic disorder. And then what's the time criteria? 1 month, and we're worried for a month that it's going to happen. Good. So depersonalization, derealization. Just a reminder of those terms. Which one is this? Yeah, right, Spider-Man. What's the, is this derealization or depersonalization? Depersonalization, out of body. And which one is this? The reality stone, so it's derealization. Good. Good job. PTSD. This is another tough one. Likely you or someone you know of has been affected by this, first or second hand. Most likely, I've watched a lot of hard dudes get wrecked by this. A lot of hard people that you think they'll never get shook by this, but they have. And some of them get help, and they put in the work, and they raise their hand, and they get better, and some don't. Try to stuff it deep down and handle it, and that's a lot of times what happens on deployment, right? You just got to keep the needle pegged and keep going, and your cortisol stays up the whole time, and then you get home and you pencil whip the post-deployment return, so you get on that block leave, and then you never get treatment for it, and it just stacks in your life. So that's why you want to lean in and help people with this. Help them raise their hand This wreaks havoc on so many things. This is why marriage and military are not a good combination. You don't say military, oh, join the military to improve your marriage. Yeah, and just your response is witness to that. Some folks get taken out of the military before they like, and tragically take their own lives, right? So we get a chance to step into this, build that rapport, and give them a safe place to raise their hand and say, I want to help you, I want to come alongside you, I'm with you, walking through this with you. Make a plan and help them. Sometimes you push the pause button to be able to do what you do and what you've been trained to do, what the military's trained you to do, longer and better when we push that pause button. But if you keep running red line and try to chop down trees with a dull axe, you get worn out real quick. Help those who can't protect themselves. And sometimes that doesn't look like when they walk in the room, you think, well, that person can protect themselves. Sometimes you protect them from themselves. And the very thing that the military trains and prizes in an individual, many times outside the military, is very detrimental to their well-being, their personal relationships, and life after the military. So be aware of that. And look at the long game. Look at the person behind a diagnosis, behind those symptoms. Ask the questions, provide a trusted space, and change your life. All right, here's the distilled out of the pink box. This looks like a super long pink box, and hopefully we'll simplify. Thank you. This words are hard. Sometimes it's tough because this requires a traumatic event. That's what it's in the name, post-traumatic, so it's got to be after a trauma. But it doesn't actually have to be a trauma. It can be a threat of a trauma. That can count in this PTSD. And so what classifies as a trauma, what severity classifies as a trauma is different for every individual. So if you see somebody and they report a trauma or they're traumatized by a certain situation or the threat of a certain situation that's way below your threshold for resilience and what is trauma in your life, don't project that on them and just say, what? No, go away. Seek to understand from their side of things, seek to understand from their shoes, walk a mile in their shoes. All right, 1 month duration, we'll make this a little clearer hopefully in a minute. Quick-tempered and aggressive, right? Real quick response, back at you, teeth tearing eyeballs. Heightened sensitivity to potential threats, and very reactive. Right? We'll talk more about that. Here's the pink box, and I've just put the letters without the description of them. So this is what the letters are. And we'll say this several times in a couple different ways. I'm going to keep going and hopefully this will make sense. Here's the long pink box. And there's more of it. The intrusive thoughts, the avoidance, negative alteration, cognition, and mood, what that looks like, reactivity, what that looks like. And then here it is, distilled out, each letter we need, and the number beside the letter are the number of symptoms of each. Hold on, we'll simplify it even a little bit more. So trauma, and then after that, and use this if it helps, but if it confuses you, just close your eyes and stop your ears. But I like to say PTSD, the 12-1-12 train. So PTSD, you're not alone, 12-1-12 on the train. So if you organize those characteristics or the diagnostic criteria so that the first letter spells train, then the 12-1-12 are the number of symptoms in each of those categories that fits. Okay, so the 12-1-12, and I got one underlined in the middle because that's the time component also. What's the time component? One what? Month. 1 month of this. Yep. So trauma or exposure to or anticipation of, that's in letter A in our diagnostic criteria. Reactivity, that's letter E, echo. Avoidance of things that trigger. Intrusive thoughts, unwanted intrusive thoughts, problem. Negative alterations in cognition. That's D. Yep. Only if it helps. 12-1-12 training. All aboard the PTSD train. All right, let's look at T. This is the first in our train, trauma. We talked about that experience, witness, or exposed to the threat of counts as trauma. to the patient, not to you, to the patient. Or reactivity. These are things that could be someone that goes to 0 to nuclear instantly. Whoa, that person. Some describe as might as well mentality. If they get into a little bit in emotions, they just take the governor off and they just let it all out. And that's that 0 to nuclear. Always scanning, right? Don't sit with their back to the door, checking the room. Remember that scene from Jason Bourne, when he said, I can tell you every license plate in the parking lot. The guy who can handle himself, the best place to find a weapon is under. He's scanning, right? That's a good description of that. Startled. This is scary startled. This is, now let's put that on the ground. This is a whoa, okay? Take your hand off the weapon kind of startled. That's what reactivity is. C, avoidance. Staying away from triggers, so they don't want to remember or get around something that makes them remember or puts them back into that trauma. That's the avoidance of those things. And the reason that is because it's at the surface and our brain has improperly stored this. And so that's part of the therapy is we want to reorder and put this in a proper place in your brain and in your memory. Right now it's still at the forefront because it's improperly stored, and so we have to deal with it. Our brain thinks we have to deal with it again every time it comes up, and then we haven't processed it. So we'll talk about that more. Intrusive thoughts, unwanted. So this is nightmares, conscious or unconscious. So nightmares counts on that. Some people don't like to go to sleep because they have these recurring nightmares because of, and that's part of what's going on. Memories, dreams, flashback, stress. And they have a psychological reaction. Negative alteration in mood and cognition. So amnesia, forgetting parts of things, selective or complete with respect to the traumatic event. Or things or thought processes such as I'm ruined or the world is terrible. They play the blame game on themselves or other people. It can be killjoy or sourpuss, no fun to be around. The scene from Lego Batman where Alfred says, you're scheduled to go to Commissioner Gordon's retirement ceremony, and Batman says, I don't want to do that. There you go. There's killjoy sourpuss. That Batman likely has some PTSD as well. Someone who says, you weren't there, you don't know, you don't understand me, you can't relate. And so somebody that has, and that's the benefit of wearing the uniform and talking to people, is that no, you weren't there that day with that event, with that thing, but you wear the uniform and we're closer to, we have a better understanding than someone who doesn't. So you are in a privileged position in that way, and that you can relate to people a little more, a little closer to. So if you've had that experience, that's another part of wouldn't wish it on you. But man, since you've been through it, now you have the ability to say, me too. And you can relate to them in that way, and they'll listen to you more. If you've been through this, if you're from a broken home, or you have a mom who's a hoarder, or you've been through trauma, whatever that condition is, you don't want to expose yourself unnecessarily to a patient in that way, make yourself overly vulnerable. But it's so helpful for someone to say, oh, you get it. And to be vulnerable in that way, to relate to your patients is a huge gift that you have and things that you've experienced in your life. All right, there it is again. So if you think of the PTSD 12-1-12 train, you think of T, trauma, reactivity, avoidance, intrusive thoughts, and negative alterations of cognition mood. And then you got your 5, 12-1-12, 1-2-1, 1-2. And 1, what's the middle one underlined for? 1 month time criteria, good job. What else could it be? Could be other things we're going to talk about today. Could just be generalized anxiety disorder. So you want to seek to understand, give them all those questionnaires, and see if there's a better explanation, a better diagnosis that explains their symptoms. Seek to understand. Good. Continue to train and hone your skills. Now there's some, first time we've seen some of these treatments here, Psychotherapy, remember, is that big umbrella. That is all, you can say talk therapy, all the therapy is underneath that one psychotherapy. CBT is one of those underneath there. And we have CPT here. And this is the only time you'll see that. Prolonged exposure therapy, that's the only time you'll see this. EMDR, remember I heard of EMDR? Yeah, that's where the therapist who's trained will move their finger back and forth, and the patient follows that with just their eyes as they recount the event, and that somehow puts that memory in its proper place in your brain, and it's highly successful when you get into it. So it's pretty cool. And you tell somebody, man, I got a plan. Let's do this. And I got a lot of people that's helped from this. There's literature behind this. And you say, why is this the only time you see these? Well, there's a lot of money that is thrown to PTSD because Congress cares about it. And PTSD a lot of times leads to suicide. And so when you start talking about suicide in the military, Congress gets really interested. So that's why there's a lot of money in research for PTSD. If you want to go into that field, you probably have some resources available to you, but that's why we have these unique treatments, is because it's been funded very well compared to the other ones. We get to meds, the only class approved to treat PTSD, SSRI. Now there's a lot of symptoms that come with PTSD. We just recounted the train. Right? You can have other meds that treat symptoms, but if we're going to treat the underlying condition, PTSD, there's only one class that's indicated to do that. That's SSRI. And those sertraline and paroxetine specifically. What's kind of beneficial of having those two as options? Yeah, one's activating and one's sedating. That's kind of nice. If you're having trouble sleeping, paroxetine. If you're having trouble staying awake, sertraline. Nice. Good job. And then adjuncts, you said other things. Prazosin is famously used in this condition for the nightmares. It treats a symptom, which is nightmares. It doesn't treat the underlying PTSD. Now you're asking, well, if I treat the symptom, won't the condition get better? Yes. And it's semantics to some degree, but you don't want to put Band-Aids on stuff without addressing the underlying condition. So that's the bottom line answer. If we're treating PTSD, we're going to use an SSRI. If we're treating symptoms associated with PTSD, we got a lot more options. So as far as the book goes, right? Trazodone for sleep sometimes, propranolol for those peripheral anxiety stuff. Careful of the blood pressure. Somebody who's in shape and has a low blood pressure already, when you give propranolol, careful. So you want to make sure they're okay. And then clonidine for hyperarousal. Somebody. What else do we use clonidine for? What is clonidine? Central 2 agonist. Good job. What is that used for primarily? What kind of med is it? Yes, ADHD. An alternative med to ADHD, non-stimulant. What's its original purpose? What's its indication? Yes, blood pressure. What does it affect? Your lizard brain. Those autonomic features that keeps those fight, flight, or freeze reaction a little more subdued, a little more dim. So that's what it helps in here, that hyperarousal, that fight, flight, or freeze. That's what the clonidine addresses, a symptom of the PTSD, not PTSD itself. So clonidine's helpful. Keep it on your radar, keep it on your options. Carbamazepine for impulsivity and anger management, and then benzos for anxiety and hyperarousal. And there's a reason that's on the bottom of the page here, a benzo. That's not a good thing to give somebody PTSD. All right, there it is from our med slide. SSRI, it's on the list. Most first line for PTSD, there it is. There's the two that are especially good for it. And y'all nailed it. Activating, sedating, sertraline, paroxetine, way to go. There's some other ones. Trazodone, famously, you'll see that used in clinic for the symptoms of sleep. There's a lot of time the trazodone is used for. Wide therapeutic range, so you can walk it up slowly. If it's too groggy, walk it back down just a little bit. It's a good one. quantity, there it is, central two angles, y'all nailed it. Good job. Also used for ADHD. Well said. All right, next disorder, acute stress disorder. This one we might call PTSD light, not to make light of symptoms or the patient, but just to say not yet PTSD. So if it looks and smells like PTSD, but it hasn't been long enough, it's probably acute stress disorder, probably this. So it's got to be 3 days to a month. So if you get on the 12-1-12 train, but you don't have the 1 month, it's probably acute stress disorder. And that's probably the best and most simplest way to say this. If you look at 12-1-12 but don't have the time component yet, acute stress disorder. They have a different wording, and this is the frustrating part of DSM. They probably farmed it out to some other group, and PTSD is this group. And say, hey guys, why don't you talk? And so we have the same verbiage. So don't get caught up in memorizing all this. It looks, if you want to classify it, that's kind of where it is on the train. But more so, if you've got 12-1-12, and you know, and you've got that picture, you've got that gestalt, you have that feel that you can identify a patient with PTSD. And this one has a little less symptoms, it's 9 symptoms, right? And it's 3 days to 1 time criteria. So it's not there yet. PTSD not yet. Acute stress disorder. What else could it be? There's some other ones. We'll talk about adjustment in a little bit. We'll put it through that rubric, so know what the basics look like, and then look at what differentiates. But PTSD and acute stress disorder, the biggest differentiator is time. There's the pink box. Pink box. And what do? CBT. Why don't we get the other fancy list? Because it doesn't have the label, doesn't have PTSD, didn't make the studies, right? So we want to go CBT, exposure therapy, and then that debriefing, mixed review, psychological debrief. So it's more of a generic version or explanation of some of those other treatments, but first line for acute stress disorder, CBT. If we're going to get into meds, that looks very similar, doesn't it? Why morphine? What morphine? Get morphine to somebody? Acute stress disorder. Why is that a good idea? Yeah, if they're actual trauma, what could be going on? Pain. Yeah. If you help their pain in this acute phase, it likely won't be as stressful to them and turn into PTSD as likely. Right? So that's part of, remember the med we give on scene for a little bit of retrograde amnesia so they don't have to remember that trauma? Ketamine is one, but more famously, it's a benzo. Midazolam. Yeah, first set. Midazolam. Yeah, that's a good one. So morphine to help with the pain so they don't suffer as much during this phase. What's the time component for acute stress disorder? 3 days to just under the PTSD threshold, which is 1 month. So up to PTSD. 3 days up to PTSD. 3 days, 1 month. Good job. All right, adjustment disorder. So we're going in this lecture from more to less severe as far as intensity goes in these diagnoses. So PTSD and then acute stress disorder is PTSD not yet. And now adjustment disorder. You can hear the intensity or severity kind of walk down as we look at this. Essential features: emotional, behavioral symptom in response to identifiable stressor. So stressor is different than trauma. Right? It's a little less, a little more JV, but it's not JV to the patient. Okay? We'll say that behind closed doors. SI and HI is real, and it definitely comes with this diagnosis as well. So don't call it JV trauma to them, but we can think it's less of a stressor is less than a trauma. We don't want a stressor to turn into a trauma. There you go. What else could it be? There's a list of suggestions. Here's the pink box distilled. Emotional behavior symptoms develop within 3 months in response to identifiable stressor. So you're exposed to a stressor, but it's okay to not have a response for 3 months, but it still counts? What's the deal there? Why do you think that is? I was exposed to this thing 2 months ago, and now I'm feeling something about it in a way. What do you think that leeway is given? Processing, okay. What could happen? What do you think a scenario could happen? That you're exposed to a stressor, but it didn't bother you for about 2 months.
It could be a recurring stressor, and
Okay.
sometimes like the brain doesn't know how to process it, so then the next time around it's processing and how it might be stressful.
Okay, I like that. Yeah. First time, not a big deal. Second time, it's a big deal. Yeah. How is the situation? Okay. Let me give you this one. If you get married and then 2 months later you think, ooh, we got a criminal record, I didn't know this, or I took this job and the interview went great, and on paper it looks good, but after being in it for 2 months, you're going, oh man. There's allowing for a honeymoon period. So first time around, looks good, and then the longer you're in it, you're going, oh man, I should have been taking this job. So it allows for the honeymoon. So that onset within 3 months exposure to it says it allows for that honeymoon period to pass, and the reality to set in of what's going on and where you are. And then it resolves within 6 months. So, if that's part of the diagnostic criteria, can you diagnose somebody before it's resolved? Can you tell the future? No, I can't. I love it if you can. I mean, I'll be a little suspicious if you can. But so if it starts, but you're within that window, you're prior to 6 months, then we're assuming we're in that category. If it goes longer than that, we'll talk about that in a minute. But that's where you are, and you can say it's not to 6 months, and so we still have a chance to resolve it. We're not beyond 6 months, so we still meet this criteria right here in this one. Does that make sense? Okay. Examples of this, and somebody talks in and you're asking about what's going on in their life, and they retired recently. Woo, got out of the military, yeah. 2 months later they go, what am I gonna do with my time? I'm bored. Nobody salutes me anymore. People just disregard. I mean, look at when they walk in Walmart. I got my blue vest on. Right? Getting married. So even if it's a good thing, man, I gotta grow up. I gotta be an adult. Having a baby. I'm responsible for this human. So you walk out of the hospital, I felt this way. I'm thinking, I got more instructions for the car seat than I do for this human. I feel like I'm stealing something. Everybody okay with this? Walking out the door, yeah. Maybe when our 2 daughters came in town last night, so maybe you'll get to meet them. Michael, she believes in Santa. He's dead, but moving to a new city, changing a relationship, shifting to a new career, relationship changes, divorce, receiving a medical diagnosis. Remember how grief, sometimes it takes a while to go from here to here. An emotional change, yep. Difficulty at school or work, financial challenges. I got this. Well, I don't got this. Environmental disaster. Not having your physical or emotional needs met. So come in a lot of different flavors, right? That's stressor. There's a pink box for it. Read that. Make sure it makes sense to you as well. What are we going to do for it? Stress reduction techniques. Good friend Martin Lawrence, WUSA. That is great. Early recognition and removal from. So self-awareness of what's causing that stressful situation. Giving them a plan. Put some tools in that toolbox on how they can deal with it. If they can't get away, or opportunities, or broaden their height and lift up their chin and say, hey, there's other jobs out there. Why don't you apply to some of those? Daily log, stress participators, responses, alleviators. so they see it written down, and it makes a little more sense. Same thing with diet log, headache log. When you write it down and you quantify it in that way, and they look back at it, it's easier to see what's going on sometimes. And in pharmaceutical, short course of things may be helpful. Be careful. Anytime we talk to benzos, I know you're probably getting sick of it. Benzos. Antihistamines are a good one. We'll talk about a few of those in a little bit. Antihistamines are good ones for the anti-anxiety ones. I'll show you some of those in a little bit. Maybe SSRI, depending on the severity of it. All right, here's a brief recap of what we just said. PTSD, all aboard the 12-1-12 train. If it's not there yet, if it looks and smells like it, but it hasn't met the criteria, 3 days to 1 month, what do we call that? Acute stress disorder, yep. And then if it's a lesser, if it's a stressor, not a trauma, and it starts within 3 months of the initiation of exposure to the stressor, and anticipated resolve within 6 months, what do we call that? Adjustment disorder. Good job. Good job. All right. Switch over a little bit. I didn't answer the question about what is it called when it goes beyond 6 months. It's unspecified stressor disorder from your definitions page. That's what it's called. Yes.
So do you know why the ICD recognizes complex PTSD but the DSM doesn't?
There's a lot of things in ICD-10 that you can say struck by meteorite. It's not in the DSM. So there's, yes, I don't know is the short answer. No, I don't know. DSM has kind of the rocks or the big rocks of the diagnoses. ICD-10 will get a lot more granular and minutiae. The reason for that is for billing purposes for your coders. So find the diagnosis that best fits your patient, and then learning and talking with your coders to say sometimes a different name means a big difference to them. And so asking them, hey, is this the proper thing to call this? Do the insurance companies see this, what I'm calling it, in these two categories into this minutiae? That's way in the weeds, but that's a good question. The ICD-10 code will go way into more detail than DSM-5 does. DSM-5. Great question. You're going to have that. You're going to get into the EMR and say, there's 500 choices under adjustment disorder. Which one do I choose? I just want to say adjustment disorder. Yeah. All right. Sleep. Let's practice first. All right, what's the question? Most likely condition, yep. Amarillo by morning, can't get away from George Strait. Right. Child or adult? Adult, male or female? Stable or unstable? Stable. Where are we? Post-deployment. So what's the attitude this person's probably going to be? All right, how much longer do I got to be here? My kids are in the car. We're headed to the beach. Let's go. Which questions do I got to say yes and no to for you to stop asking me questions? All right? Not saying everybody. That's a stereotype. All right. What does this smell like? What lecture does this smell? Trauma. Okay, we're in that realm. All right, which trauma did we call this? What are our main three options for trauma? PTSD, acute stress disorder, adjustment disorder. Okay. What do you need for PTSD? What's number one? T, trauma. Yep. We have trauma here. Yep. Good. What else do we need? 1 month. Yep. So we got a lot of dates here. We have 1 month. Okay. Yeah. 6 weeks, returned 7 days ago, it's been during this 4 months. We don't know when the ID explosions happened in 4 months, but it's been at least 6 weeks, so there's a month. Good. Good. There's the timing. Timing could be another one. If it's been more than a month, which one's off the table? Acute stress disorder, yeah. Which one's still on the table, but if it's a lesser, trauma, not trauma, but a stressor, even if it hasn't started yet, it's got 3 months. Adjustment disorder, yeah. This is a little more heavy than a stressor, isn't it? ID explosion, ID blast. Yeah. Good. How about symptoms that go with it? Do we have 12-1-12? Close to it. If it says most likely, we don't have to count. But does it smell like 12-1-12 train? Yeah, it does. It does. There you go. So we got, I'll just walk through one trauma. At least there's 3 ID blasts. Reactivity, short fuse and constantly aware of surroundings. Avoidance, avoids listening to buddy's favorite song. Intrusive symptoms, nightmares. 2, negative alteration in cognition, mood, numbness, and depression. So there's a 12-1-12. And we know we have 1 month, 6 weeks, clinically significant, not attributable to something else. There it is. Good job. Question?
I was just reading into when you're turning on and breathing, like if possible, because it's within 3 months for adjustment disorder, and it's starting to get better. So is that true for that 2 months of improving on the training?
That's a good sign, for sure. But as far as acute stress disorder before then, adjustment disorder you're talking about? Yep. You could be, if you're not sure, you don't have all this information yet, maybe that's what you call it first. But once you get all this 12-1-12, you get that information, they met the diagnostic criteria, they ticked all the boxes. PTSD. Yeah. So the thing that would take you into that realm initially is trauma versus stressor. So IED blast versus a moved to place. So good question. There it is from our sum up slide, PTSD. There's the basics of it. 1 month. There's our 12-1-12 train. Good. Here's the next question. So if we're looking for adjustment disorder, what would be a good differentiator? Time. Yeah, what's the time for adjustment disorder? Within 3 months it starts and resolves within 6 months. Okay, so we got a window, 3 to 6 months. Good. So let's look at time. So if we look at time, there's what sticks out. Do all those fit? What about the first 2? Do we have time component there? It's hard to say and call it adjustment disorder if you don't have the time component. And number 1, A, it's an 18-year-old. That person is non-existent in this class. So that's not even an option. It's not even an answer choice, right? So 6 weeks, 11 days, and 2 months. Those times, we're just looking at the time, those all fit adjustment disorder. Yes, they do. Good. So those 3 we'll keep on the list for now. Let's see. So stressful event, stressful life event, do all those have that? So we got ejecting from aircraft, Mascal, and PCS away. Stressful life event, all 3, yeah. Life impairment. Is it bothering them? Affecting stuff? They're seeing you, right? So yeah. Presents within 3 months. And then made 6 months yet, so we don't know. Good. Now, let's look at stressful life event versus significant trauma or event exposure. Can we differentiate those between trauma and stressors? Which one would be trauma? Ejecting from an aircraft, is that a trauma? Yeah. Yeah. Knowing that there's a several $1 million bill attached to your name now as well can be part of that. Moscow, is that a trauma? Yeah. How about PCS? Of the three, which one is the least as far as goes? Which PCS would likely be, if we had to label one a stressor, that'd be the one, right? Yeah. There you go. Good job. So what would A be, would you say? Phobia. What kind of phobia? Specific phobia. What's the phobia? Snakes. Ophidiophobia. Ophidiophobia. You don't want to watch snakes on the plane. Right? Okay. How about B, Bravo? What's that one? Yeah, performance anxiety, which fits underneath social anxiety disorder. Yeah. What's social anxiety? What's the key component to that? Scrutiny of others. Good job. Nice. And then C, PTSD. Okay. How about D? Acute stress. Mass cow? Come on. Oh, I heard it. What do we need for D to become PTSD? About 20 more days. Yep. And that qualifies. That 1 month. Good job. There it is. So again, you need it. There's a big box. There it is. There it is from our sum up slide. Here it is. Here's what it says. If it doesn't resolve, it pushes beyond 6 months, then it goes, here's what the differential and the DSM says about it. And that bottom highlighted points back to our definition slide. So that's what you call it. If adjustment disorder goes beyond 6 months, unspecified, it's not severe enough, doesn't have enough criteria to meet the other traumas, that's when it falls into this one. Can't jump straight to it. And that's the catch-all activities. All right, sleep. Talk about sleep for a little bit. Don't do it right now. Later. We'll do it later. There's where it is in reference material. There's our syllabus, what we're going to talk about. And there's some definitions. Central CSA, central sleep apnea, not Confederate States of America. Central sleep apnea is when respiratory effort is the problem. And then OSA, obstructive sleep apnea, is when blockage is the problem. So central is the effort and obstructive is blockage. That's the difference in those two. Hypoventilation, what's that got to do with looking at the word? Too much or too little? Too little. What's ventilation? Breathing, in and out. Yep. Not breathing enough, not breathing often enough or deep enough when you sleep. What's PSG? You know what PSG means? You'll see this a lot when you're talking about sleep. You ordered it. It's the official name for a sleep study. What's PSG? Any hints there? Oh, there it is. Say it again.
Polysomnograph, something like that.
Polysomnography. Yes, polysomnograph. Yep, that's where you order a PSG. If you're looking, I'm looking for sleep study. I can't find it. PSG, polysomnography, is sleep study. Same thing. Good job. So there's other ones, non-rapid eye movement sleep disorder and rapid eye movement sleep disorder. Those have their definition, and we only need to give one slide. All right, here's what happens when you don't get enough sleep. When you're looking at all these things, what other diagnoses that we've talked about could look like this? I mean, make a list, right? There's a ton of stuff that could look like this. And so somebody comes in, what's a good question to ask?
How are you sleeping?
How are you sleeping? And they say, I haven't slept in 4 days. Then what are you going to say? We need to get you some sleep. What's the cure for sleep deprivation? Sleep. Exactly. I'm not going to test you on these numbers, but here's the progression of how bad it gets and how quick it gets bad. And And some of y'all who've been in selection programs or things, and you say, I don't want to remember that. I'm starting to get into our trauma lecture when you bring that up. But when you stop and talking to guys who've done that, and you've probably done this too, and you say, I start seeing stuff, legit. I saw pink elephants. And my friend Crusher, he said the Planet Peanut Man came up beside him on the interstate riding his big bicycle, and he was serious. And I was looking at him, waiting for him to say, ha ha, gotcha. But he never did. Well, I got a Crusher story I'm going to tell you. So, there I was, in Mississippi, getting my alternator rebuilt, my Crusher. He's sitting at his desk doing it. I'm rebuilding my alternator. I'm sitting in a chair over here. One part of me is saying, it's been 3 hours already. I think we can move it. And then another part, man, somebody else is going to walk in with another eye exploded. I got to call somebody. But then in comes this lady, and she bursts in. You can tell, hair wet, she just had a shower, got her clean clothes on. She brought in his dinner, his plate, and it looked like they lived close to there somewhere. So she walked over, had this plate, and it was one of those cornware really thin. You can stack a bunch of them up. If you grew up with those plates, it's good eating off those plates. But it had one of those plates, and as much spaghetti as you could fit on this plate was on this plate. I bet that pile of spaghetti, I'm trying not to exaggerate, was that tall and looked like a mountain. It was impressive how much you put on it. And on top of it, there was some red sauce, and then on top of it was about 5 pieces of white bread. Wonderful, that's right. So that's what she put down in front of her, threw it down like that. She was ticked about something. And she was going off. I mean, she was cursing like a sailor, big time. And then I'm sitting there just watching this happen, and he's trying to say, and then finally he said, hey. And at the time I was a youth minister, and so he said, hey, he's a preacher. And so she didn't look at me, but she kind of looked toward me and said, sorry. And then it went from R to PG-13, her language kept going, and then she stormed out of the building. And he looked at me and said, that's my fiance. I said, okay. And he said, she's quite a woman. All she wanted for her 21st birthday was a case of beer and somebody to fight. You got good one, so trauma to her may be different than trauma to me. So she handles it very little better than me. So I don't know what that has to do with this, but yeah. I maybe lost sleep not thinking that she was right anywhere I live. Run out of people to fight. Again, if you know Crusher or you find out who Crusher is, I would love to see Crusher again. He's a good man. All right, insomnia. Insomnia is you can't sleep, even though you have opportunity to sleep. That's insomnia. These patients usually won't come to you until it starts affecting stuff and they can't do what they need to do. And there's a low level of that in the military. I mentioned before that cortisol that gets ramped up and stays up. So that's a piece of it that could be. But when they come to you, when patients come to you and say, I can't sleep and it's affecting what I do, take them seriously, because it is tough to admit that. And that's a form of, some people see that as a form of raising their hand saying, I'm weak. So don't take that lightly. Here's what it looks like. There's a lot of 3s in the sleep. 3 nights a week, 3 months. There's a lot of 3s in the sleep lecture about that. Can't get to sleep or stay asleep. So at least one of those. So sleep onset or maintain sleep. So that's one. Can you ask that question? Do you have trouble getting to sleep or staying asleep? And then you wake up before the alarm and just stare at the ceiling. Because some of that could be that you're getting rid of you trained your body really well and you wake up 3 minutes till. But if you wake up an hour before and you just stand and can't go back to sleep, that may be something. There's a big box explaining it. What do we do for it? Everybody gets it. Sleep hygiene is a form of CBT. Yep, just as effective. The literature says just as effective as any result. And you think, well, that's the magic bullet. I just give them this sleep pill, sleep med, and that'll cure them. But the literature says sleep hygiene counseling is just as effective as any. And you might have gotten Ambien, a handful of maybe 5 if you deployed across many time zones to reset your body clock. We'll talk about circadian rhythm in a minute. But that's Ambien, that's Zolpidem, that's what we're talking about. And you're thinking, man, that works. And you want to ground trial that. If you're on flight status or fly jump dive, they'll have you ground trial those meds before you take them down range, because they'll do crazy stuff. There was a doc I worked for, and he said, I'm not taking Ambien ever again in my life. I said, how come? He said, I ground trialed that, and my wife woke up to me in my pajamas with a hammer knocking out the tiles in our guest bathroom. And she said, what are you doing? And he said, I'm remodeling the bathroom. He said, I don't remember that. I don't remember either. In the morning, I woke up, dust all over. I said, what happened last night? Well, you were remodeling the bathroom. It's the Ambien talking. Right? Zolpidem. Just as effective, sleep hygiene. That's Zolpidem. So don't jump to the pill and think that's going to cure it all. Here's those antihistamines I mentioned earlier. Hydroxyzine, Atarax, has several indications. Sleep is one, anxiety is another. I love Atarax. I love hydroxyzine. I love to give that to patients and try to wean them off of Zolpidem. And some people said, man, I'm so glad you did this. Why didn't people do this earlier for me? And that is some success stories that hopefully you'll have as well. Diphenhydramine is Benadryl. I like to use hydroxyzine instead of Benadryl or diphenhydramine, because people say, what? You're going to give me Benadryl? I can do that at home. But if you give it a different name and call it hydroxyzine and say, big drug driver, right? You can take it completely. And then they think, oh man, mix that with some normalsaline, you've got a lethal combo there. But then further down, trazodone, more addictive is Zolpidem, and it has that black box warning of complex sleep behaviors, which is what I just described. My friend remodeling his bathroom in the middle of the night, not remembering it. Some of those things, somnambulance is, right, sleeping, somnolence, ambulance, walking, ambulation, somnambulance, sleepwalking, amnesia, eating, driving, cooking, so people doing stuff, so you're so familiar you can do stuff in your sleep. You heard that saying? People sometimes often do it. One time my wife used to coach track, and so I get in really late at night off the bus, so I get in bed 3, 4 in the morning, try to lay real still so I wouldn't wake her up, and then get settled in once I realized I didn't wake her up. One night, I got in there in bed and I'm waiting for her to settle down. She raised up on the elbow, and it was about this far from my face, and she said, wait. And I'm thinking, am I the baby in here somewhere? Am I laying on the kid? You're going to spill your cereal. I think, oh. And then she said, she got out of bed, she goes over to the dresser and she's messing with stuff. She goes up to the window and she says, I know the perfect place for that, clearly. And I said, where? And she said, right here, right above the window. Okay. She goes in the kitchen, turns on the lights, does some messing around in there, and then in a minute, she walks around the corner, you can tell she woke up. What is going on? And I told her what happened. We laughed for an hour. It was so funny. Complex sleep behavior. She didn't need Zolpidem to do that for her. She's an amazing woman. Hopefully she'll come in here again too, with her daughter or something. All right, here's what it could be. Insomnia differentials. We'll talk about a little bit more of those next time. We'll pick up with the dwarf. Good job, Steve Martin.